Good morning, everybody. This is Susan Henderson from Disability Rights, Education and Defense Fund. And we're with Debbie Toth today, the CEO of Choice in Aging. And she's going to talk with us about congregate living, the impact of COVID-19 on congregate living, vaccine hesitancy, and what that means for both people who are living in congregate housing, as well as the people who work there and people who want to visit people who are in group settings. So I'm going to go ahead and hand this off to Debbie in a moment. I just wanted to ask everybody to leave their videos off and mute themselves so we can hear and also hear Debbie and see Brandon, our interpreter. And also we'll have some questions at the end for Debbie to respond to, and this will be recorded and put up on our website in about 4 days. If you need interpreting in Spanish, there's an icon at the bottom of the screen that says interpretation. You can select English to Spanish, click on that and select Spanish. Otherwise, I think we're off and ready to go. Thanks everybody. Thank you, Debbie.
Great, thank you. Thanks, Susan, and thanks, Lawrence, for inviting me. I am super happy to be here. So I think that Lawrence invited me because we were fortunate to be involved in vaccine distribution in Contra Costa County. So Choice in Aging typically is not in the business of delivering vaccines. That was sort of new for us in this pandemic. We have some adult day healthcare programs. We have the multi-purpose senior services program. We provide California community transitions, getting people out of skilled nursing and moving them back into community living, intergenerational preschool with our adult day healthcare. We have Alzheimer's specialty programs. We have transportation, caregiver support. So we do all of these things, but mobile vaccine clinics were new. And so we had a real opportunity to actually deliver vaccines where they were needed, rather than the expectation that people could make it to a place with vaccines, or that if they were able to make it to a place where there were vaccines, that they were able to access the vaccines once there. Many of these larger sites were not accessible to everyone. And so we were able to go to these small boarding care facilities where people like 6-bed and under lived. We were able to go to low-income senior housing complexes, one in particular where folks had to have multiple chronic conditions to qualify to live there. So really targeting the vaccine delivery in those places and spaces. And we had really high uptake rates, and folks want to know why. Why is it that your uptake rates were so high? And this gets to vaccine hesitancy. So we knew coming into this vaccine space that there were concerns, right? This vaccine was rushed. Like, oh my gosh, what do you mean? It took 10 years to develop a vaccine for this, and this is less than a year. And, so there was certainly concern around the speed with which the vaccines were approved. Also, there's vaccine hesitancy in some communities, regardless of whether or not there was a 10-year history or a one-day history. And there are certain populations that have very strong lived experience of a mistrust of a healthcare system. And so there were a lot of different factors that would cause people to be hesitant about taking the vaccine. And so we knew going into that was the lay of the land. So what were we going to do to try and mitigate that, to try and get people to take vaccines? I will say that from our position, from Choice in Aging's position, we were working very closely from the beginning of the pandemic with the local health services and the deputy public health officer to reduce spread contain spread, and particularly with a focus on the congregate living sites, because we know that that's where the bad outcomes were happening, and they were happening at such an elevated rate. So we had started this sort of having this relationship already. We'd already been with health services, and we had watched what had happened in these facilities. And that, along with reading the science and knowing what the data was behind the development of the vaccine, knowing that we were at that time looking at Pfizer and Moderna, that the science behind it had been used in cancer treatment for years and years and years. So it was not something new. The numbers of the people that were included in the trials were hugely significant and covered age and disability and ethnicity and a variety of different categories. So there was a lot of recognition of how terrible COVID was, coupled with having the education. So we had all of that, and Choice in Aging was coming into the space saying the vaccine is the right thing to do. And so having that be our position, we wanted to share that with others. And the ombudsman services of Contra Costa, Solano, and Alameda felt very much the same way. We had done a lot of the work together. Nicole and I sat on a lot of different committees together. And so we partnered with the ombudsman. The ombudsman protects the rights of people living in those congregate facilities, whether they're residential care facilities for the elderly or skilled nursing facilities. And so this is the trusted entity for the residents in these facilities and hopefully their family members too. And so we partnered with them, and then we brought in health educators. So whether it was Dr. Sarah Levin, who's one of our deputy public health officers, who led the teams that were going into the skilled nursing facilities and residential care facilities, providing PPE, training them on what to do if you have an outbreak, how to divide your facility into a red zone, a yellow zone, and a green zone, providing PPE, providing pulse oximeters. So she's been there, she's been developing relationships. So Dr. Levin provided education, and Heather Sederma, who is a public nurse practitioner, she's with public health in Contra Costa, and we teamed up together and provided multiple sessions on Zoom with translation. We had ASL interpretation, we had Spanish interpretation. I want to say that we had Tagalog as well. So we were trying to provide opportunities for everyone to learn before we arrived with the vaccines. So we provided education from the physicians, from the nurses, from the service providers. We answered the questions of residents who lived there, of family caregivers, of the staff who work there. For us, our goal was to have all of the staff and all of the residents want the vaccine when we arrived. And we did a pretty darn good job of getting almost everyone at every site. And I believe that it was because we, one, had spent the pandemic trying to develop relationships and provide support to them through the PPE distribution, through the pulse oximeter distribution, through those nurse strike teams that were going in and providing the support and education to the staff there. So that, coupled with the education, I think is what really made the difference for us. We also were working alongside DREDF and Disability Rights California and Justice and Aging and the California Advocates for Nursing Home Reform, so that we could be ensuring that people had risk mitigation put in place with visitation and support. So there were a whole bunch of different pieces of the puzzle. So what does it look like now? So there are many board and care homes where everyone is vaccinated and where all the staff are vaccinated. And there are some where that's not true. And there are some skilled nursing facilities where not all staff are vaccinated. And not all residents are either. I will tell you, in Contra Costa, we continue on this work. And we continue to have email conversations. If we're like, oh, there's this site, and we know that they only had a 60% uptake rate in vaccines, then we go back and we say, can we provide some more education? How can we support you? We will bring the vaccine to you. You don't have to go out. So just trying to provide every opportunity to make that vaccine available and the education around it available. We literally had Dr. Levin and Heather Sederma and the nurses that were on the county side of the vaccine team available by phone to anybody who had questions or concerns. So it's education, education, education. So what is life like now if I'm a resident in a skilled nursing facility or a residential care facility for the elderly, and I require somebody to care for me and they are not vaccinated? That's real. That's happening now. If I had a magic wand, everybody would be vaccinated. I don't have a magic wand. So in the absence of that, what can we do? We can educate. We can continue to educate. We can bring the vaccine is available. We're not even full with appointments on the vaccines that we do have. So it's no longer an issue of supply. The supply is there. It's the education that has to be there. The good news is, if you are a vaccinated resident, you have a 0.8% chance of having any symptomatic COVID if you're exposed and you have COVID. So the general population, if they have COVID, 15% chance of having severe episode of COVID, severe symptoms. If you are at peak immunity with your vaccine, you have a 0.8% chance of having those kind of asymptomatic response. So it's very, 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 very minute chance that something extreme will happen with COVID from you. So there is some, I think, comfort in that knowledge that that it's very, 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 very unlikely that something bad will happen as long as you are vaccinated. I would just encourage you, if you're not vaccinated and you're scared about it, or you have concerns, or you have questions about it, reach out to your local deputy public health officer. If you're not comfortable or you have a trust issue with somebody in your area, I will connect you to Dr. Levin or Heather Sederma. They are both absolutely incredible, and it is their goal to get everyone vaccinated. And if you have questions or concerns, they're going to want to help walk you through that. They are two really committed, incredible human beings. And so I would encourage you to reach out. If you don't trust the availability of people around you and what they have to say about it, please reach out further. We are unfortunately not in a place where we can mandate that people get vaccines. And I say unfortunately because that's just, I want everybody to be vaccinated. Clearly, that's my place and space on this. I know that not everybody's there, but again, if I had a magic wand, everybody would be vaccinated. That cannot happen right now because the vaccines are under emergency authorization. Once the FDA approves them as a general approval, that's when they would be subject to being able to be mandated. Whether or not that will happen, that's a whole nother ball of wax, something I can't predict about right now. But that's just the reason why they can't be mandated now. I've had that question come up, that people are mandated if they work in healthcare settings in some counties in California to have a flu shot, for example. Vaccines are mandated for children in school. So why is it that we're not mandating the COVID vaccine? And that's because the status of the current approval is an emergency status. It will eventually become the regular approval. And at that point, that's when, if you wanted to, you could advocate to have it be mandated, but we're not at that point yet. So who can visit? How safe is it? Is it my right to have people visit me? Is it my right to have people safe and not around me when I'm in a congregate living facility. So my go-to, there are two different bodies of guidance that we get for congregate facilities. And I'm talking now about residential care facilities for the elderly and skilled nursing facilities. But there are also adult residential facilities. There are other congregate living sites, and they have different ways of communicating with their providers. So for example, in skilled nursing, the Department of Public Health releases what are called all facility letters. And those give guidance about who can come, when they can come, how they can come. And they are long and complicated and not easy to read. Shh. Anyway, no opinion there. The Department of Social Services, they do not do all facility letters. The Department of Social Services, they do provider information notices. And provider information notices from Department of Social Services are for those residential care facilities for the elderly. The difference in the guidance is that one comes from Department of Public Health and one comes from Department of Social Services. In addition, I have to say what I love about the Department of Social Services, they have a page that they do specifically now anytime they release one of those information bulletins that is specifically for the residents living in that facility. It summarizes what's in that 8, 10, 12, 16 page guidance in a one pager that's in large print, that's accessible, that's easy to understand, and that is supposed to be posted on every resident's door. So if we're looking for a really great way to disseminate information and latest up to date, I would say Department of Social Services is setting a bar, and I like it. I like it a lot. But what I like even better than those all facility letters and the provider bulletins is that the California Advocates for Nursing Home Reform have taken those long, not so easy to read documents, and they have compiled it into a spreadsheet. Now, I don't love spreadsheets when there are numbers in them, but I love them when there are categorized words in them. So if you were to go to the California Advocates for Nursing Home Reform website, which is canhr.org, if you go to their website, they have taken the most recent ones. When I say the most recent ones, I'm talking April 26th of this year is the most recent guidance that we got from both the Department of Public Health and Department of Social Services on visitation. And it breaks down the visitation on fact sheets that are set up like spreadsheets. And there's the virtual visitation and phone calls and video chats. And it tells you on each one of those, one on the nursing homes, one on the residential care facilities. So for example, I will read to you from the visitation rates for skilled nursing facilities. Virtual visitation, phone calls, and video chats. The guidance from Department of Public Health says must be available in all facilities. CMS encourages creative means of connecting residents and family members, and facilities urge to take strong efforts to facilitate connections with residents, families, friends, and loved ones. The California Department of Public Health encourages frequent video and phone call visits. While the guidelines merely encourage virtual visitation, CANR, that's the California Advocates for Nursing Home Reform, believes that anti-disability discrimination law requires all reasonable accommodations to visitation, including robust virtual visitation opportunities. So this is different than the one from the Department of Social Services. The Department of Social Services in that same category of visitation with phone calls and videos says facilities must allow and provide assistance in arranging alternate means of communication for visitors, such as phone calls, videos, and online communication. So that's just to show you the difference between the two. And that's just one area. So it goes into outdoor visitation, indoor and in-room visitation, visits from essential professionals, compassionate care visits, close contact and physical touch, and then rules for visits. So all of the rules are outlined very clearly. You don't have to read through 18 pages of state bureaucratic speak. It is very clear. And I encourage everyone to see these, to know these. If you live in a facility or you know someone who lives in a facility, if you live in a boarding care home or you know someone who lives in a boarding care home, we all can be advocates for ourselves and for our neighbors and for our friends. And the more we know, the better we can support people. This is by far the worst time to navigate I've ever seen in my life. And I imagine that most people are feeling the same way in terms of living through a pandemic where one of the things that we're told if we have disabilities, if we're aging, that we absolutely should never do is to isolate, was the one thing that we had to do to protect our life in this last year. And it's created a really difficult mental health situation for many of us to navigate. And so to the extent that we can lift up what your rights are, how you should be supported in having your social and connective needs met, how you should be able to navigate having your physical needs and your safety needs met in this time. All of the rights that you have are very clearly listed out in those two documents. And I'm just realizing I have the option to put them in chat. Holy tamale. So I am going to just copy the link to that right now. And I am not sure how to get everyone in the chat, but I'm putting it in, Lawrence, and you can pop it into the public part of the chat. I'm not sure I can do that right now, but so now everybody has a link to that. If you are unable to download that link or print those pages, call me, text me, email me. I will get them to you. It is a really fantastic resource, and I just want to give a shout out to DREDF and Disability Rights California and Canner and Justice and Aging and Senior Disability Action and all of the incredible humans that have been partnering with us to navigate through this extremely difficult time and ensure that the rights are upheld of folks who are living in these congregate facilities. And I hope that we are able to get out more education, get out more vaccines, and get to a place where we can hug each other again, because that's, to me, a big missing moment in this pandemic is hugging people. So I thank you for the opportunity to speak, and I hope I can answer questions if anybody has any questions.
Debbie, this is Susan. Thank you so much. I did have a question. Something that you said made me wonder. Vaccine hesitancy isn't unique to congregate living spaces. We're seeing, a flattening of people going after, like you said, there's no problem with supply now, but the demand isn't matching the supply because of hesitancy or other issues. And in these, I really like the way that you said you built this relationship ahead of time, and there was a high uptake, and now you've also hit that spot. So do you think that the tactics that you're using to increase vaccine uptake in these smaller living spaces can be, can transfer to, larger community groups? And if so, what recommendations do you have for for that? Is it all about the trust? Is it, what do you think?
Yes and yes. Yes, it can be, and yes, it's all about the trust. So it's not going to happen that all of us have an opportunity to build the kind of trust and relationships that we did in this pandemic, because we were a year in meetings and facilities. And, so this was a unique and rare opportunity for us to build relationships in those spaces. But there are community-based organizations and service providers and faith-based organizations. There are education institutions. There are places all throughout our community where relationships exist with historically marginalized populations, whether it be ethnicity, whether it be gender related, whether it be people with disabilities, elders, whatever that population is, they have trusted entities. And those are the ones where we should be bringing, or there's a physician in them. So for example, there was hesitancy in Vallejo. We did some work in Solano County. There was hesitancy in Vallejo. The Black and African American community did not want to get vaccines, and they didn't want to hear from a white physician about the vaccines. And so we brought in three, I should say there was African American, Black, and two other Black professionals. I'm navigating the right terminology for every situation where somebody tells me whether they prefer to be called Black or African American, so forgive me on that. But three different folks came and provided the education around the vaccine that looked like the people who were asking about the vaccine, right? So how do we provide people that are appropriate in those settings to provide the education? So Dr. Levin is a white woman. Maybe somebody doesn't want to hear that from the white woman, and so we go to Dr. Williams. So we need to be able to plug into the places where people have trust, and we need to be able to have a physician or a nurse educator or somebody from that community or place or space who can provide that education. So it's being aware of all of these different factors, plugging into existing places of trust, and bringing the right people to provide the education.
Great. That's really good. That's really good advice. I think Lawrence Carter Long, did you have a question you wanted to ask Debbie?
Yeah, if I may. Thank you. And thank you, Debbie. Really good and useful information. I was wondering if I could follow up on Susan's question a little bit in terms of relationships, building relationships with trusted entities, and making sure that our mental health, physical needs, and safety needs are met. I was wondering, I asked this last week, and I thought it was a good question, so I thought I'd ask the same of you. Could you maybe identify the top one or two things that you think we sort of learned as a result of this pandemic about congregate care, and maybe put some of those issues you've been working on for a while into sharper focus? And given everything that we've learned and faced in the past year, where would you say are the greatest opportunities for improvement right now? Thank you.
The fact that you said one or two makes me gives me a little pause. I don't know if I could just say one or two, but I will say
you can give me your top five or whatever the number is.
Okay,
but
okay,
yeah.
Okay. What have we learned? We've learned what those of us who work in this world or who have disabilities or who are aging know and have known for a long, long time is that there is not a priority given to the folks who live in these congregate care facilities, and that the system of oversight and licensing and certification is woefully inadequate, and that we have a long way to go in removing financial incentives from these care settings. And I will say there are a variety of bills that you can find. Again, I'm going to go back to the California Advocates for Nursing Home Reform. They have pages of bills, but they have some priority bills that speak directly to this. I think that first and foremost, we must address the fact that we have a history of severe and pervasive licensing violations. And they relate directly to health and safety. And those must be addressed immediately. That's without fail. We also have learned that we should, instead of investing our money in institutional care, we need to be investing our money first up front in the community. How do we create a system of social and health care that allows people to live in their community on their terms with the support they need to do so? That means that we have to invest in food and transportation and in in-home support services. We need enough caregivers. We need the ability for caregivers to get to and from people's homes. We need to pay livable wages. Like, this is a huge sort of Pandora's box that we could get into, but I will just say that, you know, we have reform that needs to happen in those living facilities, and we have to break the institutional bias that we have in our system, where we pour all the money into these institutions rather than spending it first in the community so that people can live where they choose to live with the support they need to do so. So those would be the two sort of, for me, overarching and high priority things. And I will say that we're in a moment. Everybody is seeing this right now. So where those of us who have seen this for many, many, many years, we're watching other people's awareness get elevated in the same way that some people didn't think that racism still existed in the United States. And watching what we have seen unfold over the last year has really opened eyes to that. That same thing is happening with elder care, with disability care, with institutionalization. And so I think that this is this moment. We're either going to capitalize on it and do something. And when I say we, I mean all of us. I mean all of us. I mean people with disabilities, people without disabilities, elders, young people. We all, I mean, this concept that it's okay if some members of society are okay and it's fine if other members are not, and that's on them. That should never be our calculus. We are at a place in space right now where we recognize that if one of us is not doing okay, we're all not doing okay. And this is that time where change is going to happen. But we all have to play a part in that.
Thank you. And as a follow-up to that, I was doing my news scan this morning, and I noticed one of the reports was that state of California and 4 district attorneys have sued operators of nursing homes across the state, including many in the Bay Area, for patients, dozens of patients and employees dying of COVID-19. One of the quotes I saw was that they were trading people for profits at every turn. And I wondered if you just speak to that a moment, if you would, if that's sort of indicative or reflective of the industry as a whole, and accusations here that they've siphoned off funds necessary for appropriate staffing. You know, this seems pretty heavy if you've got the Department of Justice and the district attorneys of Alameda, Marin, Santa Cruz, and LA County kind of going after them. I just wondered if you had anything that you'd want to say about that.
Well, I am grateful to see that level of action happening around that. I don't think this is surprising to anybody who's in the industry. The skilled nursing facilities in California, for the most part, are for-profit entities. The system is so broken that they can make millions and millions and millions of dollars and pay minimum wage to the caregivers who, one of the reasons that spread was happening with COVID is because the wages they were paid to work in these skilled facilities were so low that they had to work in multiple facilities. So they would get COVID in one and bring it to the next. So I think that these kinds of lawsuits elevating this will show all of these layers underneath it and what all the dysfunction is. It was really disturbing for many of us when the skilled nursing facilities got a 10% bump in their payment rates during COVID, but they weren't held accountable to any standard to show what they were using that money for. They could be pocketing it. and not paying staff. They were understaffed. They were under-resourced. They weren't providing their staff with PPE, and they were collecting additional money. Like, this is something we've seen all along. And there are some owners of residential care facilities, some owners of these skilled nursing facilities who own multiple properties with multiple histories of violations, and they're continuing to buy more properties. And I think this is really starting to be elevated. And so when we see district attorneys stepping in, and when we see the Department of Justice stepping in, I think we're going to start to see some horror stories open up. But I also hope that we're going to start to see some real fundamental change in this industry. I would love to see all nonprofit residential care facilities. I would love to see all nonprofit skilled nursing facilities. I would love to see profit taken out of healthcare. Like, if we could just understand, like, this is just something that we all as human beings have a right to, and that everybody should get dignified, person-centered care, and have that be our base. That would be amazing. So I'm hopeful, Lawrence, and I have trouble reading what you sent because I have trouble reading the stories about what happened to people, but I know they're there. and it gives me some hope.
So Debbie, this is Susan again, and we have a few more minutes. You had mentioned, you mentioned mental health, and I was just, and then, so we already know that people in nursing homes and other congregate care facilities were disproportionately impacted by the physical health of brought on by COVID. I'm sure after living through that, people who saw their co-housing, folks die, their other patients and other consumers die, and people who worked with them, there's got to be some, trauma involved. Do you think that people living in congregate housing and these facilities will be getting mental health support, counseling? Is there a plan for that to help them get over what they've lived through for the last more than a year now?
That is a really fantastic question that I do not know the answer to, but I promise you I will advocate for. I recall reading an article, and I don't know if it was in the New York Times or where I read this article, and it was from the perspective of a resident of a skilled nursing facility who was waiting for COVID to come. I don't remember if it was him or her, come to them, because it was sort of progressing down the hall, and that residents were dying, and that this person just was sitting in their room waiting for death to come to them. That was their experience of living in a skilled nursing facility in this pandemic. And you're absolutely right, how anybody can get on the other side of that and not be impacted by the trauma of it, I don't think is a reality. So I think to the extent that we advocate for visitation, we should be advocating for support and mental health support for people who lived in these skilled nursing facilities or any of the outbreak sites, because there was not just death and loss, but the way in which it happened was so traumatic. So thank you for elevating that.
Right. No, it's something you said, because we talk about it for students all the time who had been isolated in their home doing remote learning, and but people were witnessing it. We're talking about it for people who have been on the front lines in the hospitals. So, but people who were, so to speak, trapped, saw it happening, and it was devastating. So yeah, let's put it on our to-do list. All of that, the group, the Choice in Aging, Justice in Aging, DRED, FDRC, all of us. So anyway,
I think that's important, and I will say my sister is a physician at the Contra Costa Regional Medical Center, so she serves predominantly. She learned medical Spanish so that she could serve underserved Spanish speaking populations, and she's working out in the Pittsburgh clinic. And at the beginning of I would say, I don't know, maybe 3 months into the pandemic, she said, she was expressing frustration to me about people not wearing their masks because they're not sitting in the office talking to this 32-year-old Latinx woman whose husband just died from COVID and her 2 kids are sick with it and her parents died from it. Like, they're not sitting in these rooms holding up these people and dealing with these situations of real life human beings that are, their life is in a shambles and in tatters and completely in the worst possible way because people were choosing not to wear masks. So I think you're right too, those frontline workers also seeing this unfold and what kind of support are they getting, and what kind of support are the staff getting in these skilled nursing facilities that were caring for people working 12 and 16 and 18-hour shifts at multiple jobs with no PPE. Like, there's so much collateral damage, and there's so much that we need to learn so that this doesn't happen again.
Yeah, absolutely. So Debbie, thank you so much for your time. We really appreciate it. Everybody, this will be online, as I mentioned, with captions early next week, and we'll send out an alert to everyone to let them know. So if you have any, do you have any final words for us, Debbie?
I would like to say that I am super proud to be in Contra Costa County, where over 97% of people 75 years and older have been vaccinated. I think that there are a ton of people who have risen and supported elders and people with disabilities and fought for all of us to get vaccines. And I just want to hold them up high with big fat hugs and thank them for all the work that they did to really ensure that the frailest and most at risk among us are being protected and are safe. And I thank you for the opportunity to be here. And I hope that everybody gets vaccinated or has their question answered so they can be vaccinated.
Thank you so much, Debbie. Okay, everybody, take care, and we'll see you next week. Bye-bye.
Bye.